The second presenter is Craig Bain. He is the Executive Director of Maryland CRIS, which is the Maryland HIE that many of you are already familiar with, I'm sure. And they too have implemented few tools and technologies that are helping share the information and try to address the issues that we are all dealing with. Our numbers in US alone are, over 1 million cases and 85,000 deaths as of today, which, is scary. The numbers keep going up rather than plateauing. But with that, I think Dr. Bland is going to go first and talk about all the efforts that they have done in Nebraska, and then we will turn it over to Craig. So with that, Dr. Bland, takes the floor.
I'm going to share my screen, and everybody seeing my presentation?
Great. So the Health Information Exchange, or the NEHI organization, actually supports Health Information Exchange and PDMP throughout the state and region from where we're situated. And the story that I'm going to tell you about HIE and what Craig will actually tell you about HIE is that a little bit different than what you may know about HIE in your specific area of the world. But there's really about 10 HIEs that are doing very similar work, and that's what we're going to kind of cover today. So really these HIEs are advancing interoperability, bringing data democratization to consumers and providers, cultivating economic value in their communities through sharing of technologies, and delivering on a population health utility model. And I'll go a little bit deeper into all of these. And the advancing interoperability component really is focusing on delivering the promise of health information technology from from the various interoperability components to ensuring that data is available at the point of care and flows seamlessly between providers. And I know many health information exchanges focus on hospital connections. We actually connect the ecosystem from hospitals to clinics to long-term post-acute to FQHCs. If you are documenting data and you have an electronic health record, we'll connect to it. And even if you don't have an electronic health record and you're collecting data on an Excel spreadsheet, we will work with you to ingest that information so that it is available to the providers that are caring for the citizens of the region that we cover. Bringing data democratization and to consumers and providers. Nebraska is a rural state. Iowa is a rural state. South Dakota is rural, highly rural, and has tribal areas. And we really want to support not only the technology needed to ensure that this takes place, but what are the population health components that need to be in place to ensure that we can mitigate some of these rural health disparities, not only in rural, but highly rural and frontier. So we really took this very different look at HIE and PDMP in the state of Nebraska over the past couple of years, and looked at how we could truly provide some of these infrastructures and technologies at scale to ensure that rural health providers have the same access to technologies as those in urban and metropolitan areas and connected to large IDMs.
Look at that nice lady.
And
hello.
And the ability to
facilitate
this by, I think somebody needs to mute themselves. They're having a separate conversation. Cultivating economic value is really to empower consumers and providers to realize cost containment and benefits through value-based care initiatives. So we focus on various population health activities and are able to do this at scale. So delivering a population health utility is really focused on both clinical practice, the policies that influence clinical practice, and technology that influences clinical practice. Providing the aggregation and curation and the accessibility of information at scale, and facilitating these tools across the region so that we are promoting a population health utility model, as well as facilitating the activities of exchanging of information and making the PDMP data available across the region as well. So how we were able to leverage that information and having that strong infrastructure for population health utility is what you see here. This is an example of how we repurpose the infrastructure and the very foundational components of ADT that every HIE is really well versed in. And we did this with, having very robust partners, InterSystem, NextGate as our MPI, our analytics partner is KPI Ninja, which is a local Nebraska organization. ProMedica is our lab hub, which codifies all of our data on the lab side, and really leveraging all of that infrastructure investment to what you see here. So we actually stood this COVID-19 task force up on March 13th. We had a dashboard live for the department and the governor by March 25th. And we're able to update that daily and then move that to live stream through our robust infrastructure 2 weeks after that. So from early April, the state of Nebraska had this information available, and we are actually connected to 99% of all of our acute care hospitals, as well as clinics, urgent cares, skilled nursing facilities across the state. So it is robust information. They actually know at any given time what the bed occupancy rate is, what the ICU utilization is, and what the EDs are experiencing, and really led to some directional information of targeted openings and movement to elective procedures again. Here in our lab dashboard, again, you can see the power of our infrastructure and having the robust connectedness that we do. We were actually within those first 2 weeks able to really decipher numerator denominator. When the rest of the country is still wrestling with numerator denominator, we actually have that pretty nailed down here in the region as far as what tests are done, where they're done, who's getting the testing, and the basic demographics available. This is not without a huge lift by our technology partners and our data scientists here within our organization are constantly looking at this information and ensuring that we're deduplicating the laboratory tests, because we get laboratories from both the public health infrastructure as well as the hospitals and independent labs that are doing this work based on our participation in the organization. And you can see that we know, not only the positive test, but the true number, the true numerator denominator, and the positive rates, of course. And then here's a representation of what we're able to repurpose for the public health departments. And again, this is all HIE infrastructure that we turned into a pandemic response dashboard opportunity. And every health district in our state has a dashboard that we've built out. They can look at their trends. They can drill into this information to manage their contract tracing. We know deaths, we know hospitalization, and we know demographic data in some pretty granular detail. Additionally, we're able to model the IHME in our capacity forecasting. So we knew at any given time by county, and then of course we can drill down by hospital, what the capacity and forecasting would be by county, by hospital, as far as utilization goes. And you can see that, we had some pretty powerful information as far as the populations at risk, what the capacity is and was, and we had some historical benchmarking available because we had this infrastructure in place for some time. So we can look at, okay, here's the projection. What did it look like last flu season? What can we project for the future? And we're able to model that for the statewide infrastructure as well. So I'm going to actually switch over here to our live system so you can see actually how this works, and that is actually live streaming. So you can see that these are this live streaming information. This is our ADTs, and I won't show you every dashboard since this is recorded, and there's some specific sensitive information in some of these dashboards, but you can see the last refresh is about 16 seconds ago. And as we watch. It'll actually refresh about every 30 seconds, and we have some pretty granular information that is that we can drill down in. And this is available to hospital executives, the governor's office, the Department of Health and Human Services, and has really been part of the decision-making and directional information that the leaders in the state have been able to use and have provided some great insights. So the messaging here is that public health infrastructure exists that can actually support COVID-19. It's in HIEs, and this infrastructure is supporting not only the public health response, but the hospitals and how they respond, and communities at large. This robust infrastructure is necessary, and the public health infrastructure was never architected in a way that is really using utilization information to make decisions. They're really looking at, incidence and prevalence and managing from a public health response. This is more of a population health response, and this is the infrastructure that we put in place, for chronic disease management and managing all of the measures and, really our everyday work in healthcare. And we were able to quickly reutilize that because we had invested in that type of infrastructure, including, our MPI partners in Nextgate, InterSystems and their data quality, and helping us normalize and understand some of the complexities around connecting to 70+ different EHR vendors and versions. And some of the questions I get a lot is, well, how many of your healthcare systems are Epic? Over 50%. How many are Cerner? Probably the next 25%. So why do you need a HIE? Because who connects the last mile? Where does healthcare happen? It's the community clinics, it's the SQHCs, it's those long-term post-acute centers, it's that community through our social determinant of health platform that we're launching. And this is why we're able to do what we did. So I'll pause there for questions.
Any questions people have? If you would raise your hand, and I can call on you so that we don't have everybody announcing or trying to jump in. Richard, yes, raising your hand by video works as well, as long as I can see you.
Hi, thanks a lot for the presentation. Given that we're hearing that sometimes, like the Abbott test, for instance, it sounds great, and then they're saying they're getting a lot of false negatives, and so it's not as good as it was. When you guys get the data, like for tests and results, do you also keep track of like where the test came from, so that if information comes a few weeks later that the test wasn't valid, you're able to correct for that?
We do have most of that information. Again, it depends on the data quality and where it's coming from, but it's not displayed in our dashboards, but we have some access to the granularity of that information because we have a laboratory hub and some robust laboratory information.
Great, thanks.
Mm-hmm.
Trish.
Well, thank you, and thank you, Dr. Bland, for your presentation. Very interesting. My question relates to something you mentioned about why this is needed, given that many of the hospitals are Epic and Cerner. And the question really relates to how you get the hospital's buy-in. Is there, like, for example, in North Carolina, there's a state law that requires all Medicaid providers to connect to the statewide HIE, because here there's a concern about duplicating efforts that hospitals and health systems already have with their proprietary EHRs. And I recognize, I don't mean to get political, but I'm just curious what Nebraska's experience has been with participation by hospitals and health systems. Thanks.
So we don't have a mandate. It's all voluntary. We cover 99% of all acute care hospitals. We have right now close to 60% of the long-term post-acute. So we cover, I would say, 90%-ish of all healthcare encounters that happen in the state. And, you know, we don't just focus on the verb of exchanging, we focus on what's the need for information and the use cases around that. So it's great that, you know, this infrastructure exists in a proprietary infrastructure, but it doesn't provide you care gap data extracts when you need it. It doesn't provide you some of that information that's needed for the basic operations of healthcare, and it doesn't cover everything. And it doesn't cover when, you know, from a medication reconciliation, we also have 100% of pharmacies recording data. So we have all dispensed medications in the state. And I don't know how you do medication reconciliation without that piece. So it's the comprehensiveness of information, and it doesn't all exist in one EHR.
So, Jamie, I have a question that how much of this connections across the healthcare system and the data collection, comprehensiveness, et cetera, how much of that existed before COVID-19, and how much of that you had to quickly bring together to address the issue at hand?
Yeah, so the majority of it existed before. The most of our rapid onboarding has been long-term post-acute spaces. So that is where most of our new connections are generating from. Some of the urgent cares weren't participating before, they are participating now. But for the most part, all of our hospitals were participating. And we really only have one that's connected since then. So, and again, it's voluntary. We don't have a state mandate. Sometimes I would like one, but we don't have one. But I mean, there's pluses and minuses. And when you talk about buy-in, you know, we have never had a mandate. What we really focusing on is providing the value back to those that are data sharing. You know, part of our model is you have to give to get. And we're all after the same information, despite how unique we think we are. And again, I didn't grow up in HIE space. I spent many years as a clinician and provider myself, and very frustrated by hunting and pecking for data to fulfill my quality measures and HEDIS measures and whatever else regulatory was imposed. So when I came into this space 2 years ago, it was very much with the focus of population health and how we can provide a better way and not contribute to the burnout of providers.
Joe Bormel?
Yeah, so first off, thank you so much. This is just magic. It's just absolutely fantastic presentation, Jamie. So thank you for that. About 7 years ago, our local HIE, CRISP, did a presentation for our group, and they said that we asked how many hospitals they had connected. At the time, it was roughly 100, and we asked how many different interfaces did they have to build to make that work, and they said basically a different one for every hospital. And I'm curious, operationally, how much has the HL7 fire standardization worked to drive down your costs and facilitate the magic that you shared with us?
Well, none of it yet. But our partners at InterSystems, you know, we will be one of the HIEs that meet all of the interoperability requirements. Our focus is on Fire APIs, and we will be a fully Fire API enabled platform, not only in our HIE, but our PDMP by the end of the last quarter of this year. So we're very much looking forward to that. And actually part of our initiatives for this year is to focus on getting this information to consumers and having both clinical claims PDMP data available to the citizens of our state, and that will be through an API as well. So, you know, HIEs like me and Chris, which you'll hear from, we don't focus on the transaction, we focus on the value of the information and where it needs to go for the purposes of delivering healthcare and population health. And I think that's the differentiating factor of HIEs that are really in this space versus those that are not.
Thank you.
Yeah.
Bruno.
Another question. First of all, thanks for giving me. I echo what everyone else said. Great presentation. Appreciate your time. I want to piggyback on the first question about lab data. Did you have any challenges or need to prioritize access to public health labs or reference labs in order to round out the picture of diagnostic coverage relative to the pandemic?
Yeah, sure. So, I mean, when this first started, we weren't getting all the lab data, and we're actually doing a historical load of information from the syndromic surveillance system right now. And that, you know, because we have the MPI in place and can match the HIE record, that's better, right? We're able to normalize and then clean that data pretty rapidly. But it is still a lot of chasing where labs went out. The benefit of our ADT is that we actually have the lab order that comes across in our ADTs. We know if we don't get a result. And then we can actually chase that down. I would not underestimate the value of a well-architected ADT. I don't know that we actually knew that in advance, that ours were actually really good. But we certainly benefited from that work up front, and recognizes that was actually kind of a unicorn, that we actually had the order, so we could chase some of those results down and know that where it went to a LabCorp, Quest, a Mayo Clinic, ARUP, that kind of thing, and then work with the public health department to, you go get this one, I'll get that one, that kind of thing that happened over those few weeks. I will tell you, I am super thankful that that period of time is over. That was hard. I never spent so much time trying to find one result ever in my life. So.
There is one question in the chat. Sorry, Bruno, did you have a follow-up?
Thank you.
Okay. There is one question in the chat from Rita. Go ahead, Rita, and then after that, we will switch to Craig, and we'll come back with more Q&A time for everybody. Go ahead, Rita.
Yeah, I just wanted to build on the last question about labs, and just wanted to know whether the results in the HIE also include those performed in-house, so not those coming from reference or public health labs.
All of it. In-house labs, reference labs, the public health labs, wherever it's coming from, we got it.
Were there any?
And if you think about how valuable that is, if you're familiar with the public health infrastructure and the electronic and how the syndromic surveillance feeds are architected, the CDC systems were never architected to do this, right? And that's why we were kind of in the data crisis we were in. But thankfully we were. And that's why we're able to stand it up quickly.
Were there any differences or challenges in integrating those different types of feeds, or whether they were referenced or in-house or public health?
I think we have 250 different ways that we've identified COVID labs. 250. One test.
All right, great. Thank you. Wonderful presentation, Jamie, and great Q&A. So now we want to switch to Craig, who's going to talk about the efforts that are being done here with Chris in Maryland and the surrounding areas, which are very close to many of us. So, Craig?
Yeah, hi there. Thank you all for having me. Can you see my screen?
Yes, we can.
Perfect. So first, maybe I'll say, there's not much that I can offer that Jamie hasn't already discussed. Maybe I'll emphasize the fact that that the HIE infrastructure and the fact that we have these almost public health utilities in certain regions of the country is really kind of allowing us to respond rapidly to COVID-19 in this case. But there have been some other kind of unique asks, and then I'm sure there will be more in the future. I think one of the themes that you might hear when kind of I share what we've done against what Jamie's done is that we've come to very, very similar conclusions. I think we're offering almost the exact same services to our public health officials and our state leaders, as well as our healthcare providers. But we've had to do it in slightly different ways because Maryland, DC, West Virginia are very different from Nebraska or California or New York. And that's maybe one of the actually the benefits of the system, where you can have local experts working with their local stakeholders, but have kind of united themes as they go after the response. So very quickly, just to kind of refresh about CRISP, we are a regional HIE. So we started in Maryland, and we support also West Virginia, the West Virginia Health Information Network, and the DC HIE. Very much like most HIEs, and exactly, I think Jamie said it very well. Really, our goal is to make sure that that information is moving to the right places so we can add value and hopefully help our healthcare providers and our healthcare system do better. Much of what we do, and I think much of what this crisis has highlighted, is that it's really cooperation and collaboration as much as anything. We look at CRISP across these 5 services on the side of the graph, and I've mapped kind of how that flows into COVID responses. I'll kind of just touch on these pretty briefly. Every HIE has some flavor of providing data at the point of care. This is typically through some kind of secure query portal. In some cases, in our case, it's through, in addition to a secure query portal, a FHIR-based kind of in-context application. So it's at the fingertips of providers using certain EHRs. Oftentimes, as is the case with both CRISP and NEHI, this includes things like the prescription drug monitoring program, not always. We also offer care coordination, and this is, again, very typical of HIEs. Through our encounter notification service, we push messages to, for example, primary care physicians so they can do successful and proactive transitions of care. We do a lot of that kind of work with Medicaid managed care organizations, and certainly that's come in handy as we think through the COVID response. The population health side, the reporting services. So I think this is a good example of where some of the more progressive HIEs have some suite of reports, but oftentimes it depends on the data available. And so Maryland happens to be a state with global budgets. We have kind of a unique alternative payment model with CMMI, and so we have kind of access to a full Medicare claim set. We also have a hospital-specific kind of pre-adjudicated claim set that we report on. But also there's other real-time data, as Jamie showed. Certainly lab data is a really rich source of reporting functions, and so that varies pretty dramatically by region. We've always had kind of public health as our 4th service. It typically, I would at this point gloss over it because it was not a very important one, or at least it did not get the kind of attention it does now. But clearly, the infrastructure for services 1, 2, and 3 are not only supporting public health and kind of day-to-day work, but they're really essential for this kind of broad-based response. And then maybe a very unique thing to Maryland is this idea of program administration. We really, as kind of the collaborator between hospitals, non-hospital providers, and state policymakers, kind of support total cost of care model programs in kind of a number of different ways. So kind of touching on each of the core services and how they flow into COVID, and maybe I'll spend a little more time here because I think Jamie did a really, really great job talking through reporting. One of the first things we did in mid-March was to simply get access to relevant data for COVID-19 and make that known to clinicians through our normal services. So we all talked a lot about labs. I think we probably have a very similar setup to Nebraska, and that includes both the state electronic lab reporting feed, as well as the normal lab feeds we get directly from hospitals and from the commercial labs. Our Department of Health has a daily confirmed case file that they send to us, and has been a really helpful kind of source of truth as we try to validate lab results and see, what number of labs are electronically reported versus on paper, and those kinds of issues. We also are using daily surveys, both through our emergency management group, as well as one that's directly administered by us for the skilled nursing facilities, which I'll talk a little bit more about. But using all that data and the existing feeds and infrastructure, we are doing some kind of relatively basic HIE things that are extremely meaningful to clinicians. So the idea of pushing the fact that a patient has tested positive through ENS. So a primary care doctor knows about it if someone got tested at the urgent care site. When a patient presents, we make it known in the context of clinician's workflow that they have a public health alert due to COVID. We, of course, display the positive and negative lab results in our various health record tools. One of the first use cases that was requested by us was actually for EMS, and the fear was that you could have an EMS crew that transported a patient that was asymptomatic, and that some number of days later they would find out that that patient had COVID, and there would be no feedback loop to the EMS team. So we look at the run information against the positive case information to let the first responders know that they need to either self-quarantine or get tested. And of course, research in kind of limited ways has been part of the response, and disease investigation. I just have a couple of random screenshots here. But on the right side, the patient snapshot is our secure portal, and it shows that COVID-19 is listed as a care alert. I think to one of the earlier questions, we're building out some more nuance around the care alerts when it comes to things like a positive antibody test is very different from just a positive PCR. On the other side, you have our in-context application. And what this essentially is a FHIR-based app that's available in all the Epic hospitals in our state, in our region. It's available in Cerner, and it is in some Athena practices actually now. And it kind of sits nestled on the right side of the screen. It can be always open or collapsed. And kind of in real time with no clicks is doing some FHIR-based API calls to us and pulling back relevant information into kind of a simple display within the EHR. And so in this case, it's showing there's a public health alert there for a COVID positive patient. For the public health reporting, we already had a pretty robust reporting suite based on administrative data, the hospital claims and the Medicare claims. We very quickly repurposed that data set, or that reporting portal, to stand up new reports based on real-time ADT feeds, the lab results, somewhat similar to what Jamie showed, and actually taking the daily hospital survey and a daily skilled nursing facility survey to show things like capacity, change in hospitalizations over time, ventilator availability, ICU use, and even kind of PPE in nursing homes. If I had to guess what next week will look like, although it seems like every day it changes, we're very likely going to take the skilled nursing facility information and kind of tailor it for assisted living, and try and reach out to those 1,500 or so ALs in the state. One of the nice kind of highlights in that kind of the hospital and SNF capacity survey is that because the data is flowing to the HIE, we're making the results known to kind of all interested stakeholders. So all the hospitals have each other's capacity information, so they can do kind of regional surge planning. We make it available to the local health departments through our portal. The state Department of Health is accessing it. Other CRIS participants, payers are accessing it. And actually the Department of Health in Maryland is submitting the NHSN CMS survey on behalf of hospitals, and starting Sunday on behalf of the skilled nursing facilities. And so even though providers are never happy about this, about having to enter data for anything every day, they are entering it once, and it's being used across pretty much every use case you can imagine, rather than having random people call for random pieces of data kind of multiple times per day. I'm not sure I'm brave enough to do a live demo, but I just picked a couple random reports to show. So this is an ADT volume trend that we're showing across Maryland and DC. this is our version of the capacity tracking report. And so you can look at acute and ICU bed stays on the bottom and kind of available remaining capacity. And then there are regional filters and kind of a whole series of dashboards behind these. And finally, I think, Nebraska and Maryland or Nehi and Chris are good examples of HIEs that are always looking to innovate. When stakeholders ask us to try new things, if we think they will add value and are aligned with our mission, then we certainly like to try them. Two examples that have kind of arisen from this crisis. Well, one is drive-through testing sites. So the Maryland Department of Health wanted to create drive-through testing sites, but they needed some kind of physician order process, and they wanted a scheduling process. So you wouldn't have a bunch of really nervous or scared people flooding these sites all at once. And so they came to us because thanks to the prescription drug monitoring program and just our broad kind of prevalence in the region, they asked if we could build the physician order entry portal. And so we did, based on kind of referral workflow we'd already done for some community-based organization, social determinants use cases. And then of course we had to have a scheduling tool. So we quickly stood up, actually we stood up a prototype and then we moved to Microsoft Dynamics, but essentially a pretty basic platform that allows when the order is placed, the patient gets a text or an email, and then they can go in and self-schedule for the test, and then we do a check-in, check-out process at the testing sites. This is not the lab requisition process. This is simply the kind of the fact that the physician says this person should be tested, and then the scheduling requisition happens completely separate. But right now, that's actually used by 15 sites, and we have done almost 3,000 tests as of yesterday, so we should cross 3,000 today in this week alone. And then finally, kind of the other more innovative use, of course, contact tracing is one of our 4 pillars in Maryland to reopen. It's certainly one of the things that that everyone is focused on. CRISP is not a contact tracing group. I'm not sure many HIEs would want to be. But what we do have is updated demographics. And so what we have done is taken the confirmed case files, the most recent phone numbers, and we're providing them downstream, both as the trigger event, so contact tracers know who to contact trace, but then also with the updated demographics, so they have hopefully the best shot at actually contacting that person. We're taking the data then back from the contact tracers to validate the phone numbers, so we can hopefully have a continuous quality improvement process, but then also to then feed the reports, so we can start looking at things like hotspots by region and what the response was like at the state level. I think I have one more picture of just the lab order. Again, this is not very fancy or even kind of very difficult tech, but the ability to stand it up from a central location, cheap and quick, to get it out into the community is really one of the things that that Chris strives to be able to do, and we're really proud that the state, after making significant investments over the past decade, looks to us and something that we can perform on. And so with that, and I'm sure my contact information can be passed along, but with that, I'm happy to take questions.
Craig, thank you for the presentation, and I will, you talked about a lot about the data from Maryland. I know CRISP is also used in DC, so do you have the data for both, and Maryland COVID and as well as DC?
We do, so very similar to how kind of CRISP and Nehi are functioning based on kind of our local demands and landscape. CRISP between Maryland, DC, and West Virginia functions somewhat differently. And so we have kind of the longest historic relationship with our partners in Maryland, and Maryland, with its unique global budget model, kind of has provided us certain access to to maybe information we wouldn't otherwise have. But in DC, we very similarly started receiving the electronic lab reporting feed and also confirmed case file. In West Virginia, my understanding is actually that the public health officials require labs to report directly to the West Virginia Health Information Network, or the HIE in West Virginia, rather than going through the state and coming back down. But so we kind of took slightly different paths, but as what HIEs do, we kind of figured out a way to get the data and get it back out to our stakeholders.
And I know, just Kathleen, one other question, then I'll transfer to, you know, Governor of Maryland kind of has really kind of Maryland reopening plan. How much of the information that got from Chris really fed into their analysis and decision about when to open, how to open?
Yeah, a lot. So I will first kind of emphasize that CRISP has nothing to do with policy, and we would never dream to think through whether or not reopening at 5 o'clock today is the right thing to do. But what we do have is kind of really unique pieces of data. So for example, the kind of daily acute and ICU bed counts that are on the Maryland kind of coronavirus website are coming through us, thanks to the hospital capacity surveys. There's also some interesting problems you wouldn't have thought about maybe until this crisis. But even if a hospital is submitting daily bed counts, that doesn't tell you admit and discharge volume. And so to understand the number of admissions and whether or not the admissions count per day is lower than the discharges count, maybe a key indicator of capacity and surge issues, that's coming from us. And one of the kind of really critical ones from a couple weeks ago, but that I think is going to be with us for a long time, was actually the race and ethnicity data. There was kind of no other avenue in the state of Maryland to understand the race and ethnicity of the confirmed positive patients, the total number of tested patients, the hospitalizations, and the mortalities. And that's something we were able to link based on kind of access to the hospital claims information and then the admission discharge transfer feeds.
Kathleen, I think you had a question.
Yeah, there's been, you know, overall a big shift towards telehealth. And I was curious, how much data does CRISP have in terms of what that shift looks like right now?
So I'm not sure I have any good data on telehealth. This is maybe one area, and I'm sure we're not the only ones, that we've kind of always wanted to understand better and support if there was an ability for us to support it. But to date, there was not really a compelling, at least that we saw, like a HIE use case to kind of contribute to telehealth visits. It always seemed like kind of a single provider to a single vendor relationship. But it's certainly something that we'll be exploring now.
Okay, thank you.
How about Nebraska, Jamie, following up on Kathleen's question regarding telehealth?
So we've certainly explored telehealth in the past. It's really because it's tied to Medicaid, and we have to look at what, you know, really what we can do at scale. And with some of the rules being modified, we're certainly willing to support that, and providers have access to the HIE. So it's one thing that we're looking at for future initiatives, but absolutely willing to support.
Craig, Rita asks, does the self-scheduling tool require separate integration with individual providers' practice management systems?
No, so the scheduling tool essentially sits completely outside of the practices, and it's to schedule the drive-through visits at the sites that were set up by the state. And so it's more like the physician is making a referral saying that, yes, Craig should get tested, he meets the requirements. And then based on that permission, the patient can schedule, pick any site they want, pick the time they want. And then the local health departments, for the most part, are the ones who are actually doing the requisition kind of specimen collection process.
So
Go ahead.
Yeah, so just to add to that question, I was also thinking about that from the perspective of the provider wanting to know that the action actually was scheduled and the patient did go in and get, the test done. So.
Yes, so then, and this was a fun part of the problem to solve. So then we essentially become the primary results delivery mechanism. We have not had much request on the, was there an order, did the ordering physician or patient kind of get scheduled? But obviously the ordering physician needs the test results. And so we've always pushed out kind of results through kind of the encounter notifications and made them available in our portal. But that wasn't good enough. They had to be kind of much more in front of the physician in the workflow. So we also set up e-faxes. We actually set up an outbound call center to call practices when results came in. And earlier this week, we went live with kind of a results list. So the physicians could see kind of a list of the patients for whom they placed an order, and then the status of any results, whether there was nothing or positive or negative.
Craig, Kevin?
Yes, sir. So I just had a silly question. So does CRISP have any plans for if the zoonotic origins of C19 end up being a crab to change your logo? Or?
It's not a terrible idea. That's good.
No, I really just wanted to say thanks to both of you. I'm really very frustrated right now as a basically an engineer and a scientist. I just really hate the Luddite view that the world has taken and anti-science. It's frustrating to me. So thank you both.
I think we're all pretty much there with you, Kevin. I don't see any other questions, so I'm going to toss to Suniti, who needs to unmute herself.
I think Simon had a question. Simon.
Yeah, I do. Thank you. Thanks very much. I claim special status because as a Brit with no family in the state, I've traveled more than 3 times to Nebraska, and I'm not sure there are many people who have done that. But it's a question actually for both Jamie and Craig, because Craig, we all in this area know the situation with regard to population, and that essentially, DC is surrounded on 3 sides by Maryland, but also in Nebraska, there are lots of populations that live very close to state borders. And I'm wondering the extent to which it's an issue and how you resolve the issue of people living, working, and receiving their health care in more than one state, and how that works through in terms of C19, but also obviously on a general basis as well.
Sure, maybe Jamie, I'll go first, maybe speaking about kind of what we've done with our local states, and you can certainly share the maybe broader perspective. So in our region, obviously being tight with a lot of overlap, we've essentially addressed it 2 ways. One is through kind of these HIE affiliations. So if our infrastructure can be shared across borders, and that also creates economies of scale, but it solves the problem you're speaking to in a really efficient way. So that's how West Virginia and DC and Maryland are getting along. We've, for a very long time, had agreements with the DIN in Delaware to kind of just share information about each other's residents. And in other places, it's harder. We've always had trouble kind of in Virginia sharing data back and forth, where there's kind of been a less stable, less robust HIE infrastructure.
I know Virginia and Maryland are next to each other, but they don't think they work together that much.
So in Nebraska, we actually have quite a bit of regional footprint. We go outside of the borders. We connect into Western Iowa. It's really where the hospital connections end. So we have health systems that extend beyond borders. We have clinics that are represented across borders. So we go where the healthcare goes, and also share data and reciprocity with the HIEs as well. So I would say HIEs mostly are very cooperative and collaborative on sharing of information, but where the connection makes sense, we do go outside of the state borders.
Thanks very much. And thank you very much, both of you. Terrific presentations.
Thank you.
I'd like to make a statement.
Go ahead.
So, hi, this is Erkan. I just want to go back to the telehealth question. You know, I think one of the common mistakes that I see is when you talk about telehealth and COVID, what most people talk about are telehealth visits. And I think that's a common mistake. I think that counting visits is not the right metric. And that's a common pitfall that I see a lot of people falling into. I think when it comes to telehealth and telemedicine for COVID-19, there are three major goals that we should be trying to achieve. Obviously, visits is one of them, but the three major goals as I see it is, number one, you want to support the physical distancing to keep patients and healthcare providers safe. Number two is to really do the new term of forward triaging, of directing patients before they even leave their home. And number three is the maintenance of continuity of care. And what I mean by that is healthy patients at home or healthy people at home who develop acute symptoms. And we need to not forget about the chronic diseases with all the elective visits that have been canceled, who have progression of their chronic disease as well as acute exacerbation of their chronic disease. And so in my mind, it's not, the metrics is not just televisits, but it's along the lines of health outcomes, of total number of cases, number of interactions. How many of these interactions were you able to mitigate at home? How many non-COVID cases did you use telehealth for? How many did you refer for testing, not only of the person calling, but other family members in the house? How many were admitted to the hospital? How many were admitted to the ICU, and overall outcomes of that, coupled with the financial aspect of number of telehealth visits. But it's not just number of visits, it's also number of visits submitted for reimbursement and number of visits paid. I've talked to a lot of provider organizations that have started doing telehealth, but withholding their claims until there's a clearer picture of what the reimbursement landscape looks like. And then finally, you know, patient and provider satisfaction. So my point is, when we talk about telehealth for COVID-19, I think we make a mistake and a disservice by just talking about visits. And I'll shut up now.
Thank you.
Yeah, I absolutely agree with you on that, Erkan. And that's why I was really curious about what's that level of integration now with the telehealth solutions and the main EMR, and then back to HIE and that sort of thing. You know, it's really an architectural challenge that we may have in front of us to track exactly the kinds of things that you're talking about.
I'm just responding to Simon and his British.
Yeah, thank you. I was just gonna add to that. Just two small things. One is because of the data sources that we're working with, bringing in from overseas, we saw, for example, in France, there was over a 25% uptick in prescription filling in the 3 weeks. This a 25% year-on-year increase in the 3 weeks prior to lockdown. So during the period when it was clear that a lockdown was coming, people massively overfilled prescriptions in order that they would not need to go anywhere for an extended period. And the other thing, the data, the Digital Health Data Initiative project that I'm working on in Illinois is all about this process of managing how we measure what telehealth is really doing. And it's very much to Erkan's point, it's not focusing at all on just counting visits. It's quality of visits and coming up with metrics to identify the differences between different types of telehealth visit, because they clearly are not the same, but coming up with a standardized mechanism of A, defining, B, measuring, and then of course you can analyze the differences and the effects that those different types of telehealth visits have.
Yeah, thanks. You know, one of the common questions I get from docs is, just tell me what telehealth platform to use. And I'm like, no, that's the wrong question. That's completely the wrong question. And the real question and the right question that you really want to ask is, help me develop a complete plan quickly that I can activate. And other people I've talked to is, when this whole wave is over, I'm getting rid of telehealth. I'm going back to face-to-face visits. And my experience with that is they haven't developed it the right way in terms of really identifying the patient segmentation and the workflows and all the things that you need to do. And the technology is yeah.
Can I interrupt for a second? Jamie has to leave in like 7 minutes. So I want to give opportunity for other people. If you have any questions for Jamie, I have one, but I'll defer to other people first. If anybody has any questions. Okay, so the question for Jamie and Craig both. You know, now nobody was prepared for this pandemic. We didn't have enough data. We were not tracing anything. Okay, now we've got HIEs, we've got some information, we got some data. Are there any plans, or how we are going to use what we have learned to prepare for next pandemic? Because it's going to happen, maybe in a different form or fashion.
Well, I think that we've proven that there's some preparedness that that are definitely gaps in certain areas, and to leverage the power of I mean, really, it was a data crisis in addition to a medical crisis. So it's really leveraging how we can use data to be more informative, especially in the healthcare space. And what we start to look at as far as uptick in disease and use it for epidemiological purposes to look at some historical what we missed, and also to invest in these types of infrastructures that Craig and I described to you, because that's the infrastructure that's really going to promote that there won't be a next time, that we have the same type of crisis that we had as far as the data and information.
Yep. And the only thing I would add is that I wonder what kind of policies we should be looking for in the next 6, 12, 18 months, whether they're related to more robust data sharing. I'm very jealous of Jamie's nice ADT structure, but also maybe certain providers, skilled nursing facilities or urgent cares, at least in our region, that might not be as connected, but would sure be helpful to have for future surveillance and kind of disease investigation purposes.
Very good. Jamie, I know you have to leave. Any parting thoughts or comments for the group before you leave? And again, thank you very much for your time and presentation.
Nothing additionally for me. Thank you.
All right. If there's no additional sort of general comments or questions, rather, what I'd like to do at this point is to just say thank you to our presenters, to the internal team, Suniti in particular, for organizing this. I'm going to stay on for a little while for general chat if people want to, because if I disappear, I think there's a problem with hosting, so I'm okay with that. But otherwise, I'm going to stop the recording and stop the streaming on Facebook, and finish by thanking all of you for coming and joining us.
I think there was something that we wanted to, David and I talked about it, and we wanted to show before, but because of the timing, we didn't. I'm chatting with David to see if he can, otherwise I can bring it up. David?
I have it on my cell phone, but if you've got it on your laptop, maybe you can show it